We previously had a proper look at the risks involved in the intended use and those involved in all kinds of misuse of our electrosurgical system. This table summarizes all the risks we discussed. You see that even though we only picked some examples, it's already quite a list. From this list, we picked out these few risks for which we will next discuss how we could estimate the probabilities, and after that we will look into the severities. Let's start with the situation where the scissors connector on the cable wasn't produced properly. This is one of the hardest types of faults to put a hard probability number on, but a widely accepted approach for such things is to use qualitative or semi-quantitative probability ranges like those from ISO TR 24971. Then you either work with descriptions only, or you more or less translate a qualitative term into a quantitative probability. For our connector production fault, we could for example argue that there's only a remote chance of our product slipping through our well-designed production quality management system. Of course, as a manufacturer, you will try to keep this number as low as possible by designing a proper production line, having regular checks and tests and working with reliable, certified suppliers. But in practice, you will only know how often your company accidentally overlooks a bad product once they get sold and you get post-market surveillance data from client complaints. The situation with the return electrode is a typical example of a risk that should be estimated via usability or human factor studies. To see how often users would improperly place a return electrode, you could set up an observation study in which you ask participants to stick on the electrode according to the instructions and then, with each participant, measure whether the conduction of the electrode is good enough. If you repeat that with sufficiently many participants, you will get a statistical estimate of the probability of a user not putting on the return electrode good enough. In the same experiment, you could test these two situations in which the user mixed up the controls for cut and coagulate, or connected the scissors to the wrong port on the generator. These also are use errors of which the occurrence probability can be estimated by simulating the use of the device. But for the situation in which a patient with a pacemaker was accidentally sent into cardiac arrest, there are some other statistics that you could use to estimate the probability of that harm occurring in any patient treated with our device. If we assume that our patients pool is a representative sample of the general population, we can use national or regional statistics to know how many of our patients will have a pacemaker. Then, if we assume that there is no reason why our surgeons miss that their patients has a pacemaker more often than any other surgeon, we could use accident reporting information or hospital safety studies to get the probability of pacemakers going unnoticed. Next, a usability study could show how often trained users put the return electrode close to the heart in general. We could use data from pacemaker electrical safety studies to get the probability of a pacemaker failing due to an electromagnetic pulse. And finally, we could check clinical, epidemiologic and case studies to estimate the probability of a patient going into cardiac arrest if a pacemaker fails at all. Now, the product of these separate probabilities from all kinds of sources would give us the probability of cardiac arrest following the overlooking of a pacemaker, like this. For each of our selected harms, we will have to define what severity level it is. For this case, we will use the severity levels from an example in ISO TR 24971 Table 4. It has 5 qualitative severity levels going from negligible, when it results in nothing more than inconvenience or temporary discomfort, to fatal if it results in death. In our selected risks, we see severe blood loss several times, so we can treat those together. This nicely illustrates how choosing consistent terminology will make your risk analysis more efficient. Now, this leaves us with 4 unique harms: minor blood loss, severe blood loss, skin burns, and cardiac arrest. Let's couple these 4 with their severity levels. Minor blood loss during surgery may sound as if it belongs to the level minor, but if you look at the level descriptions, you see it will go to major. That's because the bleeding will have to be stopped actively during the surgery. Severe blood loss will actually go to the same group, according to the description. Although, if it would be so severe the patient could die from it, it would go into the fatal level. Skin burns will in this case be most likely temporary and hence go to the minor level. And cardiac arrest could be a harm of level major if there were no permanent consequences, but cardiac arrest could permanently worsen a patient's health. If we take this risk description a bit stricter, in this case, cardiac arrest should actually have been considered part of the chain of events, and the consequential harm could be split in the different levels of impact on a patient's health this would have, each with its own probability and severity. But for now, we will categorize it as critical, as the rehabilitation and psychological impact will most likely have at least some permanent effect. So now they're all sorted, but the risks are about the combination of probability and severity. So the next step would be to combine those and then somehow decide what risks we consider acceptable and which not.